Hello, everyone. My name is Nicole Erb, and I am the Program Manager for the National Cancer Survivorship Resource Center, based out of the American Cancer Society Corporate Center in Atlanta, Georgia. I am pleased to be the moderator for today's webinar, Psychosocial Distress Screening in CoC Hospitals, in partnership with our colleagues from the Commission on Cancer and the Cancer Support Community. Our speakers today will share perspectives on the value of psychosocial distress screening in the delivery of patient-centered cancer care and practical recommendations for integrating distress screening within CoC-accredited cancer programs. Please note there is no call-in number. Audio for the webinar will come through your computer speakers. Please be sure to unmute your computer speakers. To enhance your listening experience, you can use earbuds or headset. And if you have questions or technical difficulties during the webinar, you can enter them in the Q&A area addressed to all panelists at any time. The slide deck and a recording of today's webinar will be made available following today's call. To start, I will introduce our speakers. Nina Miller is Manager of Cancer Liaison Initiatives at the Commission on Cancer, where she manages the CoC Cancer Liaison Program and initiatives with CoC member organizations. Nina also represents the Commission on the National Partners for Comprehensive Cancer Control Programs. She holds a Master's of Science degree in social work from the University of Wisconsin and is a certified oncology social worker. Vicki Kennedy is Vice President of Program Development and Delivery for the Cancer Support Community, where she is responsible for development, delivery, and quality assurance of their clinical programs worldwide. An oncology social worker for the past 29 years, Vicki has dedicated her career to ensuring that people touched by cancer have awareness of and access to evidence-based psychosocial care. Beverly Shaw is Mission Delivery Director of the American Cancer Society National Cancer Information Center in Austin, Texas. The National Cancer Information Center, also known as the NCIC, is open 24 hours a day, 365 days a year to provide information and resource referrals to cancer patients, their families, and healthcare professionals. Beverly supports a team of approximately 175 cancer information specialists, our health insurance assistance service, the Clinical Trials Matching Service, and an oncology nurse team. Following the speaker presentations, we will have a question and answer session. We will begin the session with questions submitted by participants during the registration process. If time permits, we will ask the speakers to respond to questions submitted via the webinar Q&A box. After the Q&A session, you will see a brief survey displayed on your screen, and we ask that you please take just a few moments to provide feedback on today's webinar and offer input on topics for future webinars. I'd like to thank you for joining today's webinar, and I will now pass the microphone to Nina Miller from the Commission on Cancer.
Thank you so much, Nicole, for those great introductions. And thank you to everyone for participating today in this very important webinar where I'm going to begin speaking about the specifics of the Commission on Cancer's Standard 3.2 Psychosocial Distress Screening. So back in 2009 and through 2012, when the Commission on Cancer Patient-Centered Standards were publicized for the first time, it was a group of individuals who make up the Commission on Cancer, about 100 individuals, many of them surgeons and other representatives of multidisciplinary organizations, who looked at the Institute of Medicine recommendations on patient-centered care and determined that the standards needed to be changed, the focus of the standards needed to be changed to become more process and outcome oriented. So direct patient benefits were the focus of the patient-centered care standards, with the attempt to address that full continuum of care and provide for the patient's needs based on the patient's wants and needs. So what is patient-centered care? As you can see on the bottom of this slide, way back in March of 2001, the patient-centered care was defined by the Institute of Medicine as really being, and I think this is important to where we're at today, really being that care that respects the values, the preferences, and the needs expressed by patients, and that it's coordinated, of course, and integrated across all the system boundaries. There's a need to provide information, communication, and education to individual patients and their families or their loved ones, and that really looking at the goals of physical comfort, emotional support, and the involvement of their family and friends in their oncology care being the focus of this kind of care. So then in 2013, the Institute of Medicine really looked at where we're at with provision of high-quality cancer care, and they really said, you know, that defined patient-centered care that we have been recommending for many years now is really not that well implemented. Health systems can be complex, can be fragmented, there's too much unwanted or unneeded care being provided, and patients are excluded from the care team and decision-making, which is really the core and the center of patient-centered care. So the Commission on Cancer is hoping that through implementation of our standards that are due for phase-in here in January of 2015, one of which we're going to be talking about today, is one way in which that we can sort of move the marble and have healthcare systems being more actively involved in the provision of care that's intended to be patient-centered care, as we've outlined. So today's learning objectives from my perspective are really describing that distress screening standard that's due for implementation in the 1st of January, recognizing the options and methods that can be used when implementing that standard into practice, identifying the process requirements that are outlined by the Commission on Cancer and our recommended compliance with that standard, and then discuss how we are going to be measuring that standard compliance. As I indicated, there's really 3 continuum of care standards that are being implemented and due for monitoring of compliance of them starting this next year. I'm not going to talk in detail today at all about the patient navigation process standard or the survivorship care plan standard, as you can see those listed here. But please know that those standards due for implementation are a part of the continuum of care standards and provide very important context to the process and outcomes that we're hoping to have cancer programs achieving. Focus of today's talk, again, is on psychosocial distress screening. So what is distress? I think that this definition from the National Comprehensive Cancer Network is just a really good basic definition of what we're referencing. Distress extends along a continuum. So truly, as patients are presenting themselves to oncology care, they may be having distress that ranges anywhere from that common normal feeling of vulnerability that you might expect with a cancer diagnosis to all the way to the other end of that continuum where problems can be disabling, such as depression, anxiety, panic, social isolation, and existential and spiritual crisis. Just really important to determine where patients are at along that continuum, and thus the screening that we're going to be talking about this morning, or afternoon in some cases. So according to the National Cancer Institute and their PDQ summary called Adjustment to Cancer, Anxiety, and Distress, the prevalence for distress in patients with cancer range anywhere from really about 22% to about 58%. That range is often due to the stage and site of the cancer diagnosis. So for example, a late-stage lung cancer patient is known to have an increased percentage of those patients who are actually experiencing distress. A number that we do see in research that is commonly referenced is about 40% overall of cancer patients are really expected to be expressing a need for moderate or severe, again, as this indicates significant levels of distress that require additional assessment and potentially intervention. So this is the actual standard itself. Standard 3.2 of the Commission on Cancer says, the Cancer Committee develops and implements a process, there again that process piece, to integrate and monitor that psychosocial distress screening and referral. And I think oftentimes that and referral phrase in the standard is a little bit de-emphasized, and we're going to emphasize that for you today. So screen your patients and refer them for the provision of psychosocial care. Psychosocial distress screening is really a brief method for triaging those patients depending on where in that continuum of distress that they fall for illness-related complications that really are looking at helping those patients to achieve outcomes such as they fully benefit from their medical care and treatment of their cancer. They have efficient clinical encounters. They have increased patient satisfaction. And of course, safety is an issue with severely distressed patients as well. So this, again, are the outcomes that we're looking at trying to impact through this standard. So the Commission on Cancer has several process requirements, and I'm going to go through each one of the process requirements one by one. The first process requirement is timing of screening. So the patients with cancer are offered that screening at least one time, and that's all that's required from the Commission on Cancer, is a pre-identified pivotal medical visit, a one point in time when that patient is then offered that screening for distress. So clarifications just came out about 2 weeks ago because programs were wanting additional information about our process requirements. So these are the three clarifications to the timing of screening process requirement. So the Cancer Committee, first of all, the Cancer Committee has to define that one or more medical visits that are determined to be that pivotal time for distress screening. That the screening needs to take place at an accredited facility and or with a designated provider offices who are part of the accredited program. So if in your accredited program you have an inpatient unit, you have outpatient clinics, even if you have, as part of your accreditation, off-site satellite clinics, those kinds of things, that screening needs to take place at those accredited at those facilities that are part of your accredited program. And that the screening must be discussed at a medical visit. And this is the one clarification that I think is creating a little bit of a question out there. It's really intended that for those screened with that distress level below the cutoff, so if, for example, you're following the research guidelines for the NCCN distress thermometer, that clinical cutoff is determined to be 4. You can change that clinical cutoff if your cancer committee says we need to change this clinical cutoff from 4 to a 5 or 4 to a 3, for example. But whatever you determine to be that clinical cutoff, if those individuals in your program are screened with a distress level below that, no full assessment is required. It certainly should be documented, however. So for those who screen above the clinical cutoff, it's really important that there be an assessment of what's causing that distress for that patient and that appropriate referrals are indicated. If it's a emotional support or a psychosocial need, it's probably a referral on to a social worker, a mental health counselor, or a chaplain within your program. But it needs to be that that distress screening is discussed at that medical visit. We'll talk a little bit more about that in a minute. So when is that pivotal medical visit? And this slide sort of talks a little bit about that. There are several times within the course of an oncology patient's care where distress is probably determined to be at risk for patients. So the Cancer Committee can actually consider any kind of pivotal medical visit. The best pivotal medical visit is probably the one that can be easily tracked so that you're not losing patients through a gap. But they might be when the patient goes into remission or has a recurrence or progression. It might be when the first course of treatment is started, or at the conclusion of chemotherapy, or the conclusion of radiation treatments, or at the end of treatment completely. Any one of those things can be considered. But I did want to point out that the NCCN guidelines do say that screening should be done at the initial visit at appropriate intervals and as clinically indicated. So the NCCN is suggesting that screening should take place more than one pivotal medical visit. Also, the American Psychosocial Oncology Society, the Association of Oncology Social Work, and the ONS all came out with a position statement and said that distress really should be screened more than one time. So please, take that into consideration as you're implementing your process for distress screening. The next process requirement from the Commission on Cancer is on methodology. So determine the mode of administration. I think that research is now suggesting that a self-administered questionnaire is really the best methodology to consider as opposed to a clinician-administered questionnaire. Part of that is that patients may be more apt to be thoughtful about their responses. If they're looking at the question and providing that response, they might be less inclined to say that verbally to a clinician that would administer it. And of course, we all know that we have time constraints and that clinician-administered questionnaire may not be the most efficient use of a clinician's time. So clarification on this, and these are also two important clarifications, I think. One is that questionnaires that are distributed to a patient before they get to the clinic and returned by mail or done on a phone interview, if not discussed as a part of that medical visit, that does not meet the intent of the standard. As you can guess, if you're implementing a distress screening and you've got someone screening, if you're using a 10-point scale, and you've got someone that indicates that they have distress at a level 9 and that they are maybe even considering suicide, that you had better be looking at that screening tool at the time that they are in a situation where they can be immediately cared for by someone who can do a quick assessment and potentially referral for an immediate care that's needed at that time. So there's some clarification here about doing it within the context of a medical visit. Clarification number 5 then is for those programs that utilize an electronic patient portal. That's fine, that patients can complete that distress tool through that portal, but that those results must be looked at and discussed with a patient during that pivotal visit. So the next process requirement are tools. And I know Vicki's going to talk in a few minutes in a little bit more detail about tools. I just sort of wanted to present to you that a part of the process is selecting the tool that's going to be used to administer screening for distress, and that tool should really be a standardized, validated tool that has a pre-established clinical cutoff that was determined through the research process. And these are just a few, actually, of the many tools that are out there. And I just list them for you briefly. Again, these slides will be distributed to you, so please don't take notes if you're still in the process of selecting your tool. But in this column, the second column, it talks about how many questions are included in each one of these tools, about how much time it takes. And if you note that different tools measure different constructs. So the PHQ-9, for example, measures both anxiety and depression. But in some of the other tools that you might use, it may measure only for depression or only for other symptomatology, only for psychosocial kinds of needs. So any one of these tools and the decision about which tool to use is a decision that should be made within your cancer committee as well. The next process requirement is assessment and referral, and I absolutely underline the fact that this is probably the most important part of this whole standard compliance, that when you've got an individual who screens for distress that is above the clinical cutoff that you have established, that that patient receives a full assessment as to what is the root cause of their distress today. Now, the root cause might be, I'm having extreme pain, which is causing me to be distressed. That patient may need to be then assessed for their pain level and referred on to a palliative care team or to their medical oncologist or to the oncology nurse that specializes in palliative care, that kind of thing. The distress may be caused from psychosocial kinds of challenges like transportation, child care, that kind of thing, and they could be referred to whomever in your facility manages those challenges, whether it be a patient navigator, a social worker, a nurse, someone else within your facility that manages that kind of patient need. So the assessment is to be done by the oncologist, nurse, and it says here and social worker, but it really could say and or social worker, as long as there's a complete assessment done and a referral then, say the social worker completes the assessment and the patient really needs to be referred for that cause of distress back to the doctor or nurse, that doctor or nurse then completes an assessment of his or her own. So whoever does that assessment, they should identify and examine the psychological, behavioral, and social problems of the patient. You might say biological, physical, all the kinds of different problems that interfere with their ability to participate in their health care. So the clarification is that truly the process must include treatment or referral for treatment for those things that are causing the distress that are outlined in the screening or determined through that full assessment. I think that NCCN distress management guidelines provide a great sort of format for how you should pursue this whole process of distress screening. As you can see, this is page 9 of 72 pages of distress management guidelines. So this is just a snapshot of the overview of this whole process. In the very beginning, you can see that there's that screening for distress, and then in the next column that there is, how the patient is scoring on their distress screening tool, and then in the next column that there's that full assessment that we referenced, and then referral onto, and there's lots of really great treatment guidelines in each one of these links about the kinds of care that can be provided to help to alleviate distress. So this is really sort of a summary slide of what we've been talking about so far this morning. Patients who screen should get that assessment, that unrelieved physical symptoms should be treated according to the supportive care guidelines or disease-specific guidelines. Whatever it is that your program does provide, clinical evidence of mild distress should actually then lead you to saying, okay, then we're going to deliver like a new patient packet or just a list of the supportive services that we have available either in our community and or on site within our facility. Really everyone that is diagnosed with cancer should get those patient resources. But those who screen under a clinical cutoff should be able to be self-empowered to be able to go ahead and access those resources on their own. Documentation is then to document the screening, document the referral, or the provision of care, and then the follow-up should be documented as it would be in any instance now in a patient's medical record. Complete the SAR, which is the CoC, the Commission on Cancer's survey application record. There's also an annual application record that we just require that documents the standard compliance. That's something that if you're not familiar with that, Certainly your cancer committee or cancer tumor registrar can reference that for you. And then that cancer committee minutes are documenting your process, how you've integrated the screening, how you're monitoring it, and how you're evaluating it. That compliance then is that you've developed the process, you've integrated it into your program, you're monitoring it, not only the screening but also the referral process, and that there's somebody designated on your cancer committee, a psychosocial service representative, that's really overseeing the whole activity and doing an annual report back to the committee. So in summary, before I turn it over to Vicki Kennedy, I'm just going to provide you with these sort of bullet points of what we expect that will be done within your program. You've chosen a screening tool, you've chosen the delivery method, you've established that threshold or clinical cutoff, you're using it to triage your patients on for assessment or just the delivery of a list of community resources or internal resources. And then you're documenting the gaps in resources through probably your process that you've completed to comply with Standard 3.1, the Patient Navigation Process Standard. And then you've designated the healthcare team that can do those full assessments and how you're going to get patients to them, make those referrals to those individuals for full assessment. And then you're assessing, intervening, following up with those patients in need, documenting their care, and making that report back to the cancer committee. So I'm going to turn the ball over to Vicki now from the cancer support community. Go ahead, Vicki.
Thank you, Nina. That was terrific. And I think every time I hear you present, I learn more and more about the standard and have a better understanding of the process. And so I'm really pleased to be here today to share, to really talk about the kind of art of distress screening. There's the science of it, there's the selection of the tool, but there's also a lot about, when we talk about process, a lot about how do we best engage our systems, how do we engage the patients themselves in this process of distress screening, and how do we really implement this? And I will say in my 30 years as an oncology social worker, I've never seen really a more remarkable, exciting time where we're finally really integrating psychosocial needs and concerns into patient care. And really have to applaud the Commission on Cancer for being the visionaries to take a very bold step to help us as institutions decide how are we going to do this, that it's important, and it is truly the measure of quality cancer care. It really does, at many levels, unlocks the door to the many resources that you may have in your institution or out in the community. That distress screening, while it's not necessarily a new concept, I mean, the literature supports that people in psycho-oncology have been talking about the importance of screening people for distress for almost the last 30 years. But it's taken this evolution of time, as Nina shared, the Institute of Medicine reports, and now the Commission on Cancer Standards, that have elevated this discussion to actually change practice, so that we now connect the psychology and the biology of the care that we're providing, and that we know that that's an essential part of really doing the very best for the patients and families that we're serving. I think what's important is, and I think I'm so glad, Nina, that we often always start with that definition of distress. And as I've been working for the last several years with various cancer programs across the country, and indeed through the cancer support community, as we work on implementing distress screening across our affiliate network of Gilda's clubs and cancer support communities across the country, you have to come together and reach a universal decision in your cancer committee about what is the definition of distress that you want to ascribe to. Because it is that definition that will also lead you to which tool is going to be most effective in our setting. As you can see on this slide, there's a host of tools out there, and this doesn't even begin to touch on all of the available tools that are there. But I've tried to list some of the ones that are more frequently being used that you hear about across the country. Also, as you're looking at, so reaching that decision, so the NCCN definition of distress talks about a very broad range of emotional issues, social and spiritual issues, practical issues. It's a continuum of distress across a continuum of needs. So that's, if you ascribe to that, you're going to want to make a selection of a tool that covers a continuum of emotions and a continuum of patient needs on a variety of areas, such as physical, social, practical needs, perhaps spiritual needs, all of those things that go into really understanding the whole patient. So as you begin to look at those, and many of you may have already selected a tool, or you're still in this process of looking and evaluating tools, and we're looking at for another alternative. So one of the first choices many people are struggling with is this pen and paper. Should we use paper? We don't really have the resources to build something within our EMR or to license an external computerized tool, so we're going to start with paper. Paper can be very effective in many sites. In some sites, it may be very difficult. When we're looking at the volume of patients we have coming before us, as many baby boomers are turning 65, I think it's something close to 10,000 people a day, we know that our population of cancer patients is going to be really exploding here in the next few years. So my only cautionary tale is really thinking through a paper process and how you will manage that within your system. But it can work, and it can work well. Things like the NCCN distress thermometer, and there are also a variety of psychometric or diagnostic tools, such as the BSI-18, the PHQ-9, the depression scale, the HADS, etc. Those tend to be more psychometric or diagnostic tools that certainly can be used in screening. But remember, screening is about triage. It's about just getting to the tip of the iceberg, identifying those key areas of concerns, and then linking people rapidly into further assessment and supportive care as needed. Other programs that are available, certainly computerized programs such as our own Cancer Support Community Cancer Support Source, Support Screen from the City of Hope. Polaris has a distress management electronic computerized program. Again, you can look at the pros and cons of how you make these selections, what fits best with the definition, and what will fit best in your institution based on the resources that you have, based on the workflow of how you manage and kind of traverse patients through your system of care. And really what is most important to you as an organization about how the Cancer Committee defined implementing this tool. There are also non-validated tools and measures, and I think while certainly the Commission has made a strong recommendation urging you towards validated tools, there is a support that if you want to create your own tool that you can do so. I urge you, though, the challenge with your own tool is really that if you want to do research, if you want to really look at kind of aggregate data and compare it perhaps to other patients across disease spectrums, et cetera, you might start to run into some problems with using a non-validated tool as you move forward. But certainly screening tool selection is important. Here's an example for, as you will, for a distress thermometer problem list. I think this is the often widely used, and people are most aware of this. And it comes in a variety of forms with little check boxes, etc. I've seen sites add information at the bottom. Would you like to speak to a social worker or a chat? That distress thermometer. There's also, here's a revised emotions thermometer scale. I know of a couple hospitals using this. One case, oncology social worker happens to meet with every new patient. It's a smaller system, so they have that luxury of being able to sit down with new patients, give them the distress screening and a new patient packet with resources and information about services at that center. I think, whatever you're thinking about using, I really do want to urge you to consider a computerized version of that option. You can work closely with your IT department to think about what are our opportunities to make any of these tools available electronically, or do we have an opportunity to link with other computerized web-based solutions? We know as whether we like it or not that computers will enable us to help many more people in a more effective and efficient way. And that we need solutions that are going to enable us to use our system effectively, to identify the folks at greatest risk for psychosocial distress, knowing that risk, those that are at high distress, could affect their ability to adhere to treatment, to make it to treatment. Perhaps it's something as simple as a transportation issue, or perhaps there are a multitude of family dynamics that are affecting their ability to participate well in their care, to get optimal treatment, and ultimately to have a better health outcome. So we do need to be thinking forward. It is difficult to think in terms of depending on computers and the stress that brings, the own distress that it brings into your life, perhaps as a clinician or a practitioner. But I do want you to think about those as an option. Just to show you, for example, and many of the web-based programs work exactly like this, or similar to the Cancer Support Source. This is our own validated tool that we've been developing over the last several years. It is a web-based, completely HIPAA-compliant system with 15 or 25 items. It's available in English and Spanish, and it really provides the patient with an opportunity to not only rate their concerns, but to also tell us what kind of help do they want. And that's another important thing to think about as you're screening for distress and you're identifying these needs and concerns. Have the patient also add to that what kind of help they would want, because instead of you running around trying to figure out what I need, what information and resources and other referrals do I need to get for the patient, have that opportunity to either have the patient tell you right on the form that they're filling out, or through a conversation with the provider. This particular system generates reports, one for the patient, one for the clinician, and it has automated information and resource links that can be provided to the patient that give both institutional resources and community resources, and email alerts to designated staff. So if the patient says they want to talk to a social worker, it automates a referral to them. And, I think what's important we're actually working on a caregiver as well as hopefully soon a pediatric distress screening program. Again, it's important to think about the kind of whole piece of this. The distress screening, while it is a critical touch point for patient care, it also has application to really understanding the profile of the patient that you're serving. And if you have aggregate data that can tell you 85% of people we screened in 2014 identified problems around transportation, or 65% identified problems with their work or family or home life. Therefore, that helps you not only to think in terms of program planning and resource allocation, but also potentially help you make justification, making that case for adding staff or allocating resources within the cancer program. So something to think about as you're looking at computerized systems. Again, you can have, as Nina mentioned, where patients can access a survey perhaps through the patient portal. That information is generated to the staff. Reports are generated, and then that information is reviewed with the patient. Critical note, again, that new clarification that all of that needs to be documented at the next visit. Even if the patient, again, is within normal limits or somehow screens low for distress, it's still important to note somewhere in the medical record, however you choose to do that, patient was screened, general information provided, no further follow-up needed at this time. Or if the patient is distressed, falls over the cutoff, then you're going to put into place a referral, further assessment process within your center. I noticed one of the questions that came across was, well, what if you don't have a social worker? Well, of course, there's providers. There are CoC institutions who do not have a social worker or other psycho-oncology professional on staff, no psychologists or psychiatrists, et cetera. I think it can still be very effectively done with nurses, nurse navigators, and you can utilize formalized relationships out in the community. It could be with a mental health practitioner group. It could be with community support organization like American Cancer Society, Gilda's Club, a Cancer Support Source, The Gathering Place, whatever. Look outside in your community and find a way to create that referral information and that kind of clinical pathway, if you will, for which you create the triage, the high-risk assessment, the high-risk screening, further assessment, referral, and follow-up. And how do you close that loop for the patient in an efficient and effective way within your system? Well, you can see on the slide before you, I have to say, this is pretty much how I'm seeing, I think, both 9 and 9 others who are speaking across the country. There is a bit of that exhilaration and terror in implementing this new standard. But what a creative and dynamic time we've been afforded to be able to really put meaningful processes into place that will affect patient care and ultimately will show us, I believe, truly, that those sites that have been screening now for some time confirm that ultimately once we get the flow down in your system, once you have it moving and moving pretty well, you are going to find that you're identifying problems earlier and warding off crisis events for the patient's life, for the life of the clinical team, as problems continue to arise across the cancer journey. If we meet those sooner, we could probably have fewer of those crisis moments on a daily basis. So there are many obstacles that come to effective screening implementation. And I just have listed a few slides here to really kind of give you an overview of some of the objections and obstacles that I've been hearing across the country, working with everything from very large, complex cancer centers with 15 or 20 different clinics and multiple staff engaged in this process, all the way to very small programs who may have an oncology social worker, may not. Many have maybe perhaps a nurse navigator who's trying to set this up all on his or her own. So I think these are very real issues across providers. So one of the first obstacles I've mentioned already is this kind of lack of consensus on what defines distress and what they want to measure. Some, say, well, I only want to know if my patients are depressed. Well, then if you only pick a depression measure, have you missed the opportunity to identify anxiety or other kind of social or practical needs that perhaps are not generating a clinical depression, but certainly need attention on the part of the clinical staff to provide information and support? I've also had, we have no money to buy a tool or build one. We need to use a free paper tool. That's perfectly fine. That works and you can work to build the processes in place to make that effective. Again, I urge you to think in terms of finding a way to integrate into an electronic system. Many of you are facing, the challenge of brand new EMRs coming in, or a host of hospitals in your network that are all putting in EMRs, so the IT to people really don't want to talk a whole lot about integrating anything new. But you can at least get started with a paper tool and build your processes and work towards EMR integration. So certainly agree on a definition to key domains. Select a validated tool or program that best meets the delivery system you want to do. Are there additional features you want in there? Do you want, for example, to integrate something into your electronic scheduler so that no one has to worry about, well, when do we screen? Do we screen do we decide at the first visit or the second visit, or when they come back for at a 3-month visit or a 6-month follow-up? You need to find out what what do you need in order to track that. And really create a vision statement, some goals and a timeline. And I'll show you in a little bit how that might look, but really think about writing this up. what is our vision that we at this cancer center intend to provide the highest quality care for the whole person affected by cancer. In order to do so, we're going to implement a comprehensive distress screening, referral, and follow-up program that's going to link patients with vital information and needs to reduce distress. However you want to work on that across the path. I've had many people, though, say they sometimes feel like they're swimming upstream. They're really challenged and really struggling with being the advocate, being the voice and the champion for distress screening in your setting. And you can do that and not feel that you are really constrained because you now have the whole support of the Commission on Cancer behind you as you're developing these new programs. So other obstacles. So some of the obstacles come down to kind of staff or system support of making this happen. The staff may be reluctant, or administration, doesn't, well, it's an interesting standard, but, gosh, psychosocial care, that's an extra here. We're really here to treat the biology of this disease, and if we happen to take care of people along the way in a better way, that's great. But that's not where we are in cancer care. Today we have extensive research. If you don't have a copy of the 2008 Institute of Medicine report, Cancer Care for the Whole Patient, get it. It has every possible research information in there that you can make the case to your hospital administration that psychosocial care is no longer just an extra or a nice thing to do. Distress screening and psychosocial care are now considered an integral part of quality cancer care, and that we have to consider one and the other hand in hand. I know there's a real life concern that distress screening is going to delay or disrupt the clinic flow. Busy clinics, everybody's working hard. The front desk people are saying, we can't do anything more. What, you want me to hand out a tablet computer to everyone that comes in, or to explain a form about distress screening? Again, we have to think in ways of how we can implement this efficiently and effectively, and so that the staff is involved in helping to decide the pathway. So extensive preparation, training, and buy-in from the whole team. That includes the office staff, your IT team, the nurse navigators and the nurses who are delivering care, the physicians, and really get everybody involved in working on the roles in the pathway of how this is going to work. And then test it out. Test out the implementation and recalibrate, reassess. Oh, gosh, we really thought it was going to work this way, but it's not working. Know that any time you implement significant change in an institution, it takes time to move it forward. There are also a lot of biases out there, and a lot of people are concerned, well, how are patients going to respond to distress screening? And I think, I think it can be helpful to develop a little card or a flyer or a brochure that explains what this is and why are we asking them. And I think, of course, if you hand a tablet to a patient and say, fill this out, we're just screening you for distress, that may not go over too well with some people. But if you said to them, we here at St. Mary's Cancer Center are really concerned about you and your family and how you're doing through this. And we just have a brief questionnaire that will help us better help you in this process. So we need to have a way that we can help people to work through it. There will be people who will refuse. You can document that in the record. And sometimes it isn't about a pivotal visit, it's about your own physical looking at them assessment. If someone appears to be in crisis, perhaps it's an excellent opportunity to consider distress screening. There's also a computer bias. A lot of people say, well, our older patients won't want to use the computer, patients won't like it, computers just seem so cold and unfeeling. Well, I can tell you that a host of computerized programs have engaged patients in the process. Patients often surprise us in our bias that they're not going to use a computer system or a tablet computer are completely unfounded. I was recently in a clinic with a woman well into her 80s who was screened on an iPad. She took the iPad back to the desk, and when she sat down, I asked her about her experience with it. I said, did you find it to be difficult? And she said, oh, no, dearie, I Skype on an iPad with my grandchildren all the time. So we were making assumptions about her ability or interest to use a computer. And indeed, in fact, many of them are well-equipped and open to a simple system that can be effective. We do have to practice a script with all the staff that's engaged with screening, from the front desk person to the nurse that checks them in, et cetera. And we really have to be flexible and provide assistance as we can. Nina did mention earlier about the self-administered test versus a staff test. I urge you not to consider staff doing the distress screening. Research supports that patients do answer more effectively and more honestly when they're filling it out on their own, even though they know that you're going to be looking at it. And obviously for patients who have low reading ability or perhaps a language that you don't have a screening tool available in, of course you're going to have to provide assistance to them as needed. And that's fine, and you can document it as such, just as you would with an informed consent. This is really no different. Other kind of obstacles, sometimes people say, oh, it's just too much work and too difficult to gather and maintain data. We have limited resources, and we just don't have the money, and there's so many other demands on us. And I even have had a few clinicians say to me, well, we already know what our patients need. We have support groups. We have the chaplain comes to see them, and the nutritionist is available. We've got this already in hand. And I urge you to think about some of the data that shows that even patients with moderate distress, they can present extremely well. They look good, and oftentimes that's our physical assessment, right? Oh, she looks well today, appears to be smiling, engaging with staff and others. And what we really don't know is what we don't know about that person who comes through. And I see screening as a wonderful opportunity for us to get all of those people that are kind of in the middle. They're not so low distress that they're doing well and just aren't really having any crisis or concerns. They aren't so distressed that they immediately become apparent to us as a healthcare team that they need immediate intervention. But all those other people in the middle that are in need of more information and support, and perhaps it's something as simple as a booklet that tells them about community resources or services in your community. And what we have found is that patients who are at least even offered that information on a regular basis report a higher satisfaction with their provider. At the end of the day, we also know that patient satisfaction is a driving force in how we're measuring quality care. So screening is yes, all about patient care, but it's also about data. And we have to have a commitment to data collection and program evaluation that helps us drive our cancer programs to optimal levels, and to really think about how we can use this information to measure patient satisfaction, to think in terms of program planning and resource allocation. I know that's not the primary emphasis of the Commission on Cancer Standards that's dedicated to quality understanding of the patient experience, but this data provides us with as an opportunity to demonstrate not only the needs that are available, but the outcomes. So if I screen a patient, first-time patient, say at second visit, so they've had their first visit, they received their diagnosis, they're coming back to do treatment planning or to start treatment, and that's when they're screened. And then I rescreen them at the end of treatment, perhaps, maybe at the end of their radiation treatment. And if I can see that there has been a decrease in the level of distress, a decrease in the number of items of distress, I now have some outcomes that I can demonstrate to my administration, to our patient population, and to the healthcare providers, to the physicians, et cetera, that the information, assessment, referral, and follow-up is indeed making a difference in patient care. So really it is an art of doing distress screening. It's about thinking about the script, thinking about how we're going to explain this to everybody that touches that patient in that visit. How is the patient going to be receptive and understanding? How are we going to create a culture And really, you know, I have to say I'd probably change this slide today, not just around creating a culture of screening, referral, and follow-up, but creating a culture of whole person care or whole patient care, that whole patient-centered definition that Nina referred to. How do I do that? And I have to understand the culture and politics of my institution, because what works across town at one institution may not be effective at my institution. Or even within my institution, what works well in the breast clinic may not work well in radiation oncology or in the chemo infusion center or in the inpatient unit. So again, your task will be to develop a kind of workflow and pathway for how you will implement this across your institution. And I also want to encourage you to think in terms of your community organizations as resources, whether there's a local or national resource that's helpful for that patient and family. You need to define and engage and educate your key stakeholders. Don't just consider your key stakeholders to be people within your institution. You can create, and the Commission does support this, very meaningful contractual or formal or informal referral relationships with providers in the community to help your institution meet this need. Your institution does not need to hire 10 social workers or 10 navigators to necessarily make this happen. There is a creative way that you can engage community resources, because you are not going to be able to do it all the time. So you want to develop a screening program protocol. You know, when, what are you going to use? Where are you going to screen? How is it going to be done? Meaning, who's going to hand the patient a tablet? Who's going to explain it to them? Who's going to collect that tablet or that piece of paper back? And where is that piece of paper going to go? And how are you going to then follow up with that patient and ultimately document that in your electronic or paper chart? You really need to address fears related to the number of referrals, this fear that how often I think Nina and I have heard, oh gosh, once we start asking, we're going to uncover a hornet's nest of problems that our institution can't take care of. We are barely managing to kind of manage all of the patients we're coming through. How can we possibly meet all of the number of referrals and the workload that this might create? I really throw out to you, if you set up a good program that's efficient and effective and does the work that it is intended to do, and you have some key champions in your system that work it through, and you utilize community organizations or community resources as best to your ability or that are appropriate, that you can actually you're not going to see a decline in the number of referrals, but you're going to see a greater efficiency in the referrals that you get. Instead of a referral, say a typical social worker referral, please come down to the breast clinic to see Mrs. Jones, she's crying, okay? So now all of a sudden, imagine you get an email referral that tells you, alert, Mrs. Jones has requested to talk to a social worker about concerns for her children, transportation, and financial and insurance concerns. All of a sudden now I have immediate information as I either go to the clinic or I follow up with Mrs. Smith on the phone. I have now more information to begin that conversation. And so hopefully it will make my time more efficient and more effective as I'm working with that patient. We want to create scripts and quick guides, whether it's a handout you give to patients, assign staff, and really work on your community resources and have that information available. Some of you may have Cancer Matters in your market, which is a pre-described kind of directory of resources for your community, or you may have developed your own. And ultimately, give it time. Do not expect that overnight you're going to have all of the solutions and have it working smoothly. Many sites have told me it takes them about 3 months to start seeing the groove and some of the benefit, about 6 months where they start to go, wow, this is really working. And then kind of reorganizing and recalibrating to where it becomes a standard part of care. And you're no longer worried about distress screening any more than we worried about doing basic vital signs and labs on patients coming through our door. It becomes the norm in our system. So think about what are your challenges. This slide really talks about, you know, some sample challenges. Write this out. Make a grid for yourself and your team. What are the greatest obstacles that you're facing? You know, maybe the staff or the physicians aren't buying in. Maybe administration doesn't quite get the importance of this. Or you've been given limited or no new resources to implement this new program. Write your goal. Where do you want to be with this? And how are you going to get there? Are you having trouble with that clinic staff paying any attention to this or thinking that it's going to be, you know, kind of disruptive to their workflow? Bring them lunch, bring them breakfast, bring them cookies. Find any way that you can to sit down with them, explain what you're doing, lay out the pathway, perhaps not as a done deal, but as a draft, and say, tell me, what do you think? What's going to work best in your clinic or in your doctor's offices, and how can we help? And really, you can work really problem by problem through, develop a goal, a tactic, and a strategy, and work to your ultimate results. So I think that I know we're going to do broader questions as we finish, and we're looking at your questions as they're coming in. As we mentioned, this presentation, you can access both the slides and a recording, and we're also going to be working on kind of a master frequently asked question document to share with all of you on the call today and from our call last week. So I really appreciate the opportunity. I want to give you, tell you to hang in there, to be bold, to be a champion for distress screening. It is probably one of the more important, significant patient-centered standards that we can have before us today in cancer care, and I really thank you for the hard work that you're doing. I'm going to turn it over to Beverly, who will take it from here.
I don't know if I started before the line was unmuted, but I wanted to thank Vicki and Nina for their presentations. As I listened to what they had to say, I could see so many opportunities where the National Cancer Information Center can work together with your hospitals in providing some of the support that you might need. The National Cancer Information Center is the 24-hour, 7-day-a-week, 365-day call center that is available to cancer patients, caregivers, and healthcare professionals any time of the day or night. We get a lot of very emotional calls. In fact, I would say most of them have a psychosocial component to it. Even though we deliver information, we are really critically in tune with the fact that people need to know how to use that information. So as your hospital establishes a psychosocial distress screening process, the American Cancer Society, and specifically the National Cancer Information Center, can be a valuable partner in helping you navigate patients to resources and the information that can help address many of those needs that are on the lower end of the distress thermometer. So our services are designed to empower patients by helping them be more prepared and to further engage in having better conversations with their healthcare team, helping them feel that we take chaos and try to turn it into a more logical progression of actions, which is right in line with patient activation. And we also are great listeners, so we're able to neutralize many of the fears that people have when they first enter on a call with the National Cancer Information Center. We navigate through a needs assessment, the potential physical, the psychological, and skill-related barriers that these constituents may have, and our goal is impacting them both in the short and the long-term health and quality of life outcomes. And I'll talk to you in just a minute about how we do that. When we started in 1997, there were only 10 cancer information specialists and 1 certified oncology nurse. We presently have 175 to 200 specialists on diverse teams. These include cancer information specialists, health insurance assistance team, a clinical trials matching service, We deliver services in both Spanish and English, and we also have a language translation line so that we can support other constituents that maybe don't speak English or Spanish. And we now have 9 certified oncology nurses that work with psychosocial issues as well as helping them understand some of the more complex questions they might have about their diagnosis, such as their pathology report. So the NCIC is a great place to call. Say if a patient's going to have a visit with their doctor the next day and they had some questions from the last time they met with their healthcare team, our certified oncology nurses can help with that. The National Cancer Information Center takes in over 800,000 calls a year, and about 2/3 of those are cancer related. We do have an income portion to the NCIC which deals with even web support and events. But in addition to our cancer information specialists, as you can see here, we have 35,000 contacts a year through health insurance, assistance questions, clinical trials, and nurse questions. We also take these questions by email, and over the last few years we have now expanded into chat. It's very interesting to me that phone contact has remained about the same over, I'd say the last 5 years, but and emails are decreasing rapidly, but chats are growing more rapidly than emails are decreasing. So people are contacting us in a lot of different ways depending on where they are. For example, email and chat comes in sometimes from international geographic areas. The most common types of calls that we get are around cancer diagnosis and treatment options, and also prevention and detection. But the biggest area is really around stress issues, the fear of death, communicating with loved ones, the lack of decision making and the knowledge about their cancer diagnosis and treatment options, concerns about long and short-term side effects depending on what treatment option they choose, the inability to work, the lack of insurance, and probably the #1 and growing need is around financial devastation. We talk about nutrition and physical activity, which includes some of the complementary therapies that also help with psychosocial stress, such as meditation and other forms of complementary therapies. We talk about pain and medications, and then we also have patient services that the NCIC will do the intake for these. We can help people with transportation and lodging. And then when it comes to clinical trials, once we help them figure out some of the trials that they're most likely to be eligible for, many times those clinical trials are not within their local area. So we can help them with transportation and lodging so that they will get that additional treatment option if that's something that they choose and need because perhaps they're not responding to traditional treatment. We also talk to people about survivorship. We have a lot of calls around end of life, especially with caregivers. And then I have to mention that we get a fair amount of calls that are either suicide or even greater numbers of abuse calls, which is really sad for people to have to deal with those issues on top of going through a cancer diagnosis. So in summary, I just wanted to let you know that we are here. We educate, we give information. We have over 40,000 resources in our database, and we can look at those all the way down to the zip code and county for that patient. So we can line them up with not only local resources, but we have over 400 national resources as well. People like the American Psychosocial Oncology Group, the Patient Advocate Foundation, the Cancer Legal Resource Center, and we work in we work in conjunction with them so that our patients can be provided the very best opportunities to solve some of these issues that they may not have access to otherwise. So we can work in conjunction with your social workers as well. So NCIC, in summary, provides a menu of services designated to support the cancer patient throughout the continuum. We support them with emotional and stresses to find resources to improve their quality of life. We encourage healthcare providers to refer patients to NCIC, and we also, and just in addition to all of those other things, one of the things that we often hear from patients is how grateful they are to have a listening ear, someone that can help calm them down. We use positive language and to support those emotional needs, and especially in the late night and in the middle of the night, that we're there all the time. And then once again, I mentioned that we offer this in English and Spanish and use that translation line for those people with other languages. I tried to show this when we did this presentation once before. The NCIC has some wonderful videos that really give you a great overview of the kinds of, not only the kinds of services that we provide, but it gives you insight into what our cancer information specialists are like. And once you get this deck of slides, I would really urge you to look at both the NCIC video that is listed here, and the Society's YouTube channel has a whole host of videos that go into great detail, not just about information, but about psychosocial support as well. So I thank you for giving me this opportunity to talk to you, and I certainly look forward to anybody that would like to contact me. My name is Beverly Shaw, and my email is beverly.shaw@cancer.org. And with that, I'll turn it back over to Nicole.
Thank you, Beverly. Thank you for that presentation, and thank you also to Nina and Vicki.
Great. Nina, I know both of us have been kind of responding to some questions that we've been seeing them as they've been coming in, all really great questions, and really reflect people's hard work at really trying to work on the implementation. Nina, one question I see here, and it does come up a lot, it goes back to what you were saying about if patients complete something at home, so say they got a new patient packet and included in that was a distress screening. Could you just reiterate again, because I see the question again, can the distress screen be mailed to the patient and then reviewed with the patient when they arrive for their teaching day? And I believe that, yes, that's true, but you want to kind of reiterate that piece of it?
Yeah, thanks so much, Vicki. I'm going to actually pull these slides back to the clarification about that. I know that there are several questions here that talk about that, and I believe that this methodology question clarification number 4 is what you may be referencing here. So let me just reiterate that here. Questionnaires or forms that are distributed or returned by mail and or phone interviews without a discussion at a pivotal medical visit, I think that's the critical piece here, do not meet the intent of the standard. So you can't just send it out, mail it, and or even have a phone interview if there is not a discussion at a pivotal medical visit. And the reason why we're doing this, and I know that this is a bit of a change for several programs across the country, but the reason that we're doing this is really we feel like some of the questions that reference whether or not the patient is a suicide risk or in extreme stress are really important questions to be able to ask these patients to really determine those patients who may be way high on these distress scales and way high on their screening results. So we feel like from a patient safety perspective, these questions need to be answered in the course of a medical visit so that they can be addressed by the medical team, especially for those individuals who score high on the distress scale or are expressing a suicide risk. So hopefully that's very clear, that mailed questionnaires are not really meeting the standard compliance as we have determined it. Now, again, another clarification, you can see on number 5 is that an electronic patient portal is okay as long as that's reviewed at the time of that patient coming in for that medical visit. I'm sorry, go ahead.
So 9 hours just so that they can review it. As long as someone reviews it, it could be the nurse, the physician, whoever's checking, seeing the patient that day would check it just like they might check their labs or anything else. But the follow-up, so say a social worker or the psychologist or the navigator is going to be doing the follow-up, they don't have to, all that follow-up doesn't have to be done at that exact visit, as long as someone has seen the patient, notes it in the chart. Now, obviously, if the patient's in crisis, then you implement a crisis kind of usual response. But if the patient just has distress, needs some follow-up, you don't mean that the social worker has to come down and do all of that work right at that visit. They could do telephone follow-up after it's documented in the record that the patient was seen and further follow-up is needed.
Absolutely.
Okay.
Absolutely, yeah.
Because I think a lot of people are reading that and worried, oh my gosh, does that mean we have to do all of the referral and follow-up at that in-person visit? And that's not the intent, right? We just want to, I think the commission, right, just wants to be sure that somebody's kind of eyeballing this patient and seeing and kind of documenting that I see you've, completed this and, here's what we're going to do next. So.
Yeah, I think that one of the things that maybe is helpful is to really be thinking about this in 3 different sort of pockets. There's a screening pocket, an assessment pocket, and a referral pocket. And each one of those are sort of standalone, but they're all vitally important to the process of screening someone for distress and referring them on for services as indicated. So the screening is done. You determine which patients need to then move on to the assessment process. Certainly taking a look at the screening tool and determining where the patient is at via the screening is an important part of that sort of the very first part of the assessment. You look at it, you see the patient is not screening for significant distress, and you say, okay, that's great, let's document. That patient's been screened. I think they're going to be self-empowered to, address their own support needs, and they move on to, whatever it is that medical visit was for that day. Those individuals that are higher than that, you've got someone, a nurse, a physician, a social worker, taking a look at that patient because that's why they're there for that medical visit today, and they're saying, okay, let's figure out who needs to be involved with this patient, because it looks like they're high levels of distress. Now let's look and see if we can assess what's causing that distress so that we can make appropriate referrals. And then you jump to that third pocket, and that's that referral process. So that can be done certainly, as it would normally be done within the course of that patient's care.
So sites that don't have, say, a psycho-oncology professional on staff or accessible, what would you suggest around that when you say assessment? So I noticed there was a question from Kristen Phillips. Can you define what constitutes a full assessment? So maybe could you talk a little bit about what that would look like in a cancer center?
Well, and I might turn part of that response back to you, Vicki, because I think that you're out there and involved with a lot of these programs that are developing these. But certainly an assessment is looking at whatever the root cause of that distress is. So, is this patient have underlying comorbidities? Does this patient have a stressful family situation? Does this patient have sort of concrete barriers that are keeping them from accessing their care, like transportation or child care? Does the patient just have a lack of understanding as to what's happening with their diagnosis or with their treatment, and just need somebody to sit down with them in sort of maybe a low literacy sort of an environment to explain to them that this is what your diagnosis means, this is what your treatment course is going to entail. There's just so many different parts of a psychosocial assessment and I actually might just say a biopsychosocial assessment, because I think that physical, biological, social, emotional, all of the aspects of the patient are appropriate to be assessed to determine what it is that may be causing that distress. But I would ask you actually to add to that response.
Well, no, I think you hit it directly. I've seen sites that have a kind of referral path in place where the initially, so it's often the first point of contact after they've completed the screening and they're checking in. It might be a physician assistant, it might be a nurse that's looking at the results either on the computer screen or on a piece of paper. And so to me, the initial quote-unquote assessment begins as a conversation, right, with that patient that kind of connects back to the screening that perhaps could say, gee, Mr. Brown, I see that, you identified that you're feeling pretty distressed today, or you have a lot of worries and concerns. Sometimes patients don't know what you mean when you say the word distress, so sometimes we have to think about how we define that. But it begins with that conversation, and you will know as a professional immediately if it appears that there's a lot more here. That person may be very, like you said, able to be very articulate about what's upsetting today. Maybe they're distressed because they're there to get test results. And so their acute distress for that moment is around that visit. If it's longer term, more systemic distress that is in their family and their financial or their personal life or their spiritual life, then I think that conversation then I need to think as that check-in person, who else can I connect this patient with? Who else do I have on staff that is it a navigator? Do I have, does this patient need a true mental health assessment or a full social work assessment? And I kind of make that decision. So I think every site's doing it a little differently, just like they did before they were screening. Every site managed complex issues that came up. Now we're just standardizing it a little bit differently. What other questions? It seems like I've noticed a lot of questions lately about this January deadline and the phasing in. And I guess it would depend on when a site surveyor was coming next. Can you explain that at all a little bit more fully?
I can try. I think that if I see in some of the course of the questioning that I think there may be a misunderstanding out there, I think it's a misunderstanding about the terminology phase-in. And I want to just sort of remind everybody that the phase-in is really that dates back to our publication of these standards in 2012. So we're really working under Commission on Cancer Standards 2012 at this point in time. And at that point, we were saying in the next 3 years, we really want programs to be gearing up to be able to be ready as of January 1 of 2015 to sort of, if not already implementing a screening process, a referral assessment process, and a referral process for their patients, that they're ready to sort of push that button on January 1 of 2015. So really it's been a 3-year sort of process for the Commission on Cancer to suggest you need to be taking a look at what your processes are for completing each one of the process requirements that we discussed today. So hopefully that helps to clarify kind of what that date meant. It's not we're phasing it in as of January 1, starting January 1. It's we're phasing it in so that you're ready to start to screen, if not already, those patients as of January 1 of next year.
Mm-hmm. That makes sense. That makes sense. I know that it's that referral and follow-up that it can be a little intimidating to some sites. I think that again the idea of of mobilizing resources, and I think I have to say, I think some sites are overthinking it. Like, we need to think very simply. It's about a brief survey that identifies the areas of concern, a process by which we decide who needs to be seen further, more in depth with a further assessment, as you said, that bucket of assessment, and then linking people to resources. And even people with low distress who may not reach a clinical cutoff can still benefit from getting resource information. They may not need further assessment and problem solving around particular issues, but it's always nice for them to walk out the door with some resource information about programs in your institution or programs out in the community that they might find of help. So, and then, again, I think there continues to be questions about how do you document that, and do we have to document even someone who scores, who's within normal limits or is low screening, and I think the Commission's position is that yes, it never hurts to document patient screened for distress, scored within normal limits or low, no additional assessment needed at this time. Resources provided. It's very simple. It could be a checkbox that you have in your EMR. Just check. Patient screened, no further assessment needed, resources provided, just so they know that you can document. And we want to build this in. I think of our Canadian friends to the north who see distress screening as the sixth vital sign, and that, I have a feeling someday when we get through all of this implementation challenges, we'll step back and look at this and say, that's really what we're doing. We're really doing a very quick check in order to identify those folks in the greatest need.
Right, and Vicki, I think the only thing that I would add to that, and I don't know if maybe either you or Beverly want to just say something as well, but I think the only thing to add to that, absolutely, on target description is to say, not to forget that you all have internal resources to provide for support and concrete needs and, treatment of those who may be coming with a comorbidity of mental illness or, for all of these patients along their continuum of distress, but also that there are many community organizations and national organizations that should be provided, to these patients, especially maybe to those who fall under the clinical cutoff, that they can call the American Cancer Society toll-free number or visit their local cancer support community and, get the support that they need through those kinds of organizations. Those are very appropriate referrals if your assessment determines that those things will help to meet the patient's defined needs. So I know we're coming up on the last hour, but I wanted to just sort of reference, the importance of our partnerships with our community organizations, such as the two of you are representing today.
And Nina, this is Nicole. I'd just like to thank you for that. And also, in closing, since we are coming up on the half hour and we don't want to take anyone over, I just want to say a reminder that the slide deck and a recording will be available after the call to all attendees, as well as a copy of the questions and I believe the answers. Nina, Vicki, am I correct on that?
Correct. Okay. Yeah, we're working on, it'll take us a while. We had, well over close to 700 people on both calls, so we'll amass those questions and work on kind of short answers and provide those. I think ACS is working on a plan for distribution. So we also want to shout out to our ACS staff across the country who are also maybe listening in on the call. It's great to have you here and to have to have you have that understanding for so many of the institutions that you work with. So it really does take kind of a village to implement this standard well, and I think it's a great example of how we can all work together on this process.
Agreed. So with that, I would just like to extend a big thank you to all our participants for joining today's webinar, our speakers for your contributions, and our virtual meeting partners for your support. Have a good afternoon, everyone. Thank you.